السلام عليكم ورحمة الله وبركاته. اليوم إن شاء الله بنبدأ ثاني محاضرات The Clinical Neurology Summer Course بعنوان Approach to Stroke. قدمها دكتورة هميان الغيثي، طبيبة مقيمة في سنتها الثالثة في تخصص المخ والأعصاب من مدينة الملك عبد العزيز الطبية بجدة. ينوه على ملء استمارة التحضير التي سترسل في الشات في نهاية اللقاء، وجميع الأسئلة سيجاب عليها نهاية المحاضرة بإذن الله. تفضلي دكتورة.
الله يعطيك العافية. طيب بسم الله. نتكلم عن stroke. We'll discuss different aspects of stroke, including definition, risk factors, stroke syndromes, approach to stroke by history and physical examination, investigations, and we'll finish off with the management and complications. And the reason why I chose this topic is because it's one of the commonest neurological diseases that we see on daily basis. Besides, it's the most common neurological emergency. Stroke, the term usually refers to either cerebral infarction or non-traumatic cerebral hemorrhage. It's characterized by acute or abrupt onset of neurological symptoms. It can vary between very disabling symptoms to mild symptoms, depending on the area or depending on the vascular territory. The second characteristic of the stroke is that it follows a vascular territory. Regarding epidemiology, it's quite common, as I said before. Almost 1 of 4 people will be affected in their lifetime. It's the second leading cause of death in the world, following the cardiovascular diseases. It's the third leading cause of disability in adults globally. And on local statistics, it's estimated that Saudi population suffer from a stroke every 20 minutes. So it's a very common disease. So risk factors can be looked at in terms of modifiable and non-modifiable risk factors. 90% of strokes are attributable to modifiable risk factors, luckily. For non-modifiable, including age, advanced age, gender, like males are more prone to have strokes than females, ethnicity, genetic makeup. In terms of modifiable risk factors, hypertension, DM, smoking, dyslipidemia, also cardiac diseases makes it more likely to have a stroke. So stroke types can be divided into ischemic and hemorrhagic stroke. Ischemic accounts for 85%, luckily, because it has better prognosis than hemorrhagic stroke. Ischemic stroke is mostly due to embolism, either from an atherosclerotic plaque or cervical atherosclerosis in the arteries of the cervical arteries, or from the heart. So embolism from different sources. It causes decreased blood supply to the affected area, resulting in infarction. Hemorrhagic strokes account for 15% of the whole strokes. It's caused by rupture of a blood vessel due to different etiologies. We'll discuss these etiologies later. This rupture of the blood vessel causes blood to leak out through the cerebrum, and it can cause compression on the area and subsequently neurological deficit and possibly high ICP. So we'll move on to the classification of the ischemic strokes. We can also say its mechanisms, how the ischemic strokes happen. So it can either be a large artery atherosclerosis, like one of the major arteries, the middle cerebral artery or the anterior cerebral artery. It can be lacunar infarct, affecting the small penetrating branches that branch off the large vessels. It can also include cardioembolic, when the embolus comes from the heart, it originates from the heart. It's referred to as cardioembolic. We have also strokes of other causes. We'll discuss about it later, and stroke of unknown cause. So first is large artery atherosclerosis. So as I said before, it involves the major supply to the brain. It can be extracranial or intracranial, depending on the patient, and it can be visualized on imaging. Small vessels, it's different. We're talking about the branches that branch off the large arteries. So in large artery, we have the artery itself, the cortical branches, and the deep or perforating branches. Small vessel occlusion or small vessel strokes, it involves the deep, small penetrating branches. It can cause wide variety of presentations, and it can be classified into syndromes. We call it lacunar syndromes. Depending on which area is affected, patient will have certain presentation. These are the most common lacunar syndromes that we see. We have pure motor strokes, pure sensory, sensory motor, ataxic, hemiparetic, dysarthria, clumsy hand, and hemibilismus. So pure motor stroke, it involves the area that's called internal capsule. So we have the internal capsule. It is divided into anterior limb, genu, and posterior limb. The motor fibers are mainly passing through the posterior limb of the internal capsule. Therefore, any ischemia there would cause the patient to have deficit, mainly motor deficit, weakness, in the face, arm, and leg. Some patients, they have dysarthria. Dysarthria is not really localizing, so it can involve the cortex, the subcortical structures, the brainstem, cerebellum. So dysarthria is not really a localizing sign. Pure motor strokes can have as well dysarthria. Pure sensory strokes, so it's only sensation that is affected. Therefore, the affected area, it's the thalamus. It can involve also different areas, but the most common is the thalamus. The patient will present with a contralateral sensory deficit, face, arm, and leg. Sensory motor syndrome, it's a combination. Therefore, it will involve the posterior limb of the internal capsule as well as the thalamus. Because it's involving the posterior limb itself, it will present with motor deficit only, but it has to involve the thalamus to cause a sensory deficit. All of these are contralateral because the blood supply of the brain to an area, the motor fibers and sensory fibers will decussate. After descending from the cortex, they will decussate. Therefore, any deficit will be contralateral. Ataxia hemiparesis, it's also involving the posterior limb of the internal capsule. Patient will have impaired coordination as well as weakness. Dysarthria, clumsy hand, multiple areas can involve the caudate, posterior limb of the internal capsule, putamen, pons. The patient will have weakness in one hand and dysarthria. Hemibilismus, it's mainly involving the basal ganglia. So it's one of the movement disorders like chorea. Bilism has more large amplitude than the chorea. Therefore, the localization would be in the basal ganglia generally. So we'll move on to the third classification, which is the cardioembolic strokes. It accounts for 20% of all strokes. As I said before, it's where the embolus originates from the heart itself. It can be due to different diseases, atrial fibrillation, most commonly because it's it increases the risk of having a stroke by 5-fold compared to a normal person. It worsens with age. So as the patient ages, as they have high risk of atrial fibrillation and higher risk of strokes. Also, anterior MI, mechanical valve also can precipitate strokes. Rheumatic mitral stenosis, endocarditis, infective endocarditis namely. We have multiple other factors, but they're considered mild and low risk, like LV hypokinesia, cardiomyopathy, congestive heart failure, PFO, congenital heart defects like PFO, ASD. These all can cause stroke. Therefore, part of the stroke workup is to do an echo and Holter to look for these causes, especially if the patient's presentation is suggestive of cardioembolic stroke. Other causes of stroke, we have hypercoagulable state. These are mainly seen with patients who are young. So stroke in the young, less than 55 years of age. These are the most common causes we see usually. So hypercoagulable state, like antiphospholipid syndrome, protein S or protein C deficiency, sickle cell anemia, fibromuscular dysplasia, arterial dissections, especially if the patient presented with neck pain, headache, young patient with trauma, coming with neurological deficit, neck pain and headache, you should have to think about arterial dissection. Vasoconstriction of the cerebral vessels from substance use is also a common mechanism of stroke. Sometimes strokes you cannot identify the cause. Therefore, there is an entity called stroke of unknown cause or undetermined etiology. It's accounting تقريبا 25 to 30% of ischemic strokes, don't know the cause. So we'll move on to the hemorrhagic stroke, least common, less common than ischemic stroke. It's, as I said before, it's a rupture of a vessel inside the brain, causing the blood to leak in the area and cause neurological symptoms. It has multiple etiologies, multiple causes. The first and the most important is the hypertension, and the most common. We have also multiple causes like aneurysmal rupture, like venous thrombosis, like strokes transforming to hemorrhagic transformation, multiple causes. It can present differently, like subarachnoid hemorrhage, for example. These hemorrhages, as the name suggests, its location is in the subarachnoid area. Therefore, you can see in the image, the blood is inside the sulci, not the sulci, it's inside the deep structures of the brain. Star shape. It can be caused by rupture of an aneurysm, AV malformation that ruptured as well, trauma. The patient would present with the worst headache in their life. We call it like thunderclap headache. It can have also meningeal symptoms with it, neck pain, neck stiffness, photophobia. Patients can also have symptoms of high ICP, like visual symptoms, tinnitus, papilledema upon examination, nausea and vomiting. And diagnosis is made based upon the brain CT. So it's highly sensitive. Whenever a patient presents with headache and they have subarachnoid hemorrhage, the CT will immediately show the hemorrhage. It's going to be very hyperdense and bright, as you see in the image. Sometimes we need an LP to look for xanthochromia, which is a yellowish discoloration of the CSF because of the presence of blood. But the most definitive or the gold standard is to do cerebral angiogram, but it's not feasible to do it initially. Therefore, we depend on the brain CT and the LP. The other type is the intracranial hemorrhage or the intracerebral hemorrhage. It's most commonly due to hypertension. So when we have long-standing atherosclerosis and hypertension, these blood vessels tend to rupture. And mainly we see that in the deep structures of the brain. So the like the thalamus, the basal ganglia, the pons. Therefore, hypertensive hemorrhages tend to cause bleeding within the deep structures of the brain. Least commonly, it can cause bleeding in the lobe or intralobar hemorrhages. The other causes of intracerebral hemorrhage, it can include cerebral amyloid angiopathy, brain tumors, AV malformations, anticoagulant use as well, but it contributes to the size of the hematoma rather than causing the hemorrhage itself. Symptoms, it's similar to the subarachnoid hemorrhage symptoms, but less severe. They will not have the worst headache in their life, but they will have headache, as well as nausea, vomiting, and focal neurological deficit. Sometimes they might have altered level of consciousness depending on the size of the hemorrhage and how much compression it's causing on the structures of the brain. And this entity, also the most sensitive test to do initially is the brain CT. It's going to be bright, the hemorrhage site, like we see in the image. We call it hyperdense, similar to the bone density. Brain structures are varying between hypodense and isodense, but the blood is hyperdense, similar to the density of the bones. Finished the ischemic stroke and hemorrhagic stroke. Now we'll move on to what's the difference between a stroke and TIA. So the main difference is that the TIA symptoms resolves completely. However, the stroke, the symptoms persist and they might improve, but they will not resolve completely. That's the main difference. In terms of etiology and symptoms, they're all the same. There's no difference. The patient will present similarly. That's the main difference. We'll move on to the blood supply to the brain. It can be divided based on the arteries. So we have the middle cerebral arteries. It's responsible for the supply of 2/3 of the brain. So it's a major supply to the brain from the MCA. Anterior cerebral artery and the posterior cerebral artery. The middle cerebral artery supplies the lateral surface of the brain, but it takes from the frontal lobe, the parietal lobe, the temporal lobe, but not the whole lobes. The anterior cerebral artery, it supplies the medial surface of the brain. It takes from the anterior frontal lobe and the parietal lobe, but only the medial parts of them, not the whole lobe. The posterior cerebral artery, it supplies the occipital lobe posteriorly, and branches off to supply deep structures of the occipital lobe. There is another way to look at the blood supply to the brain is by dividing it into anterior circulation and posterior circulation. Anterior circulation, it mainly originates from the internal carotid artery, divides off to MCA and ACA. This is the anterior supply. Posterior supply, it originates from the vertebrobasilar system to form the PCA. And they join together through the circle of Willis. So the circle of Willis, it's localized at the base of the brain. It joins the anterior circulation with the posterior circulation. So as we can see, the upper part of the circle it's consisting from the anterior cerebral artery, both right and left. They join together with the anterior communicating artery. From the lateral aspect, right and left, you can see the internal carotid artery emerging up. It's connected to the PCA. You know, PCA, it originates from the vertebrobasilar system. So the basilar artery branches off eventually to give the posterior cerebral artery. And underneath the posterior cerebral artery is the superior cerebral artery. هنا يسموها نخلة. فعندنا البازلر artery بعدين تطلع منه superior cerebral artery and the PCA. But how it joins with the anterior circulation through the PICA or the posterior communicating artery, right and left. So if we ask about the structure or the components of circle of Willis, it would be the anterior cerebral artery, anterior communicating artery, internal carotid artery, PICA, and PCA. These are the main components of the circle of Willis. So one of the unique aspects of stroke is that you can identify which vessel is affected by the patient's presentation. So we have different syndromes based on the affected vessel, like MCA syndrome, ACA syndrome, PCA, basilar, and so on. So patients with MCA syndrome, like I said, MCA is supplying the most, 2/3 of the brain. Therefore, it takes the frontal lobe, parietal lobe, and temporal lobe. So patients will have a lot of symptoms, and sometimes they're disabling symptoms. So they will have contralateral weakness and sensory loss, and that's because the MCA territory covers the primary motor cortex and the primary sensory cortex. So would it affect the whole limbs or only the upper limbs? So it's going to affect the upper limbs more than the lower limbs, including the face as well. Patient will have also gaze deviation because of the frontal eye field in the frontal lobe. So they will have gaze preference. If you look at the patient, they will have gaze preference to a specific area, and this area would be the area of stroke. So they will have deviation towards the side of the lesion. Patient also will have contralateral homonymous hemianopia because of the optic radiation going through the MCA territory, depending on the area. If it's a superior division of the MCA or inferior division of the MCA, patient will have different visual field defects. But it should be always contralateral. They will have aphasia, but only if it's in the dominant branch. So most of the people, the right-handed, therefore the dominant lobe would be the left lobe, the left hemisphere. Therefore, MCA stroke in the left side would cause aphasia, but on the right side, the patient will be not aphasic. They will have also hemineglect, but hemineglect is the opposite of the aphasia. They will have hemineglect if it was in the non-dominant lobe, so in the right hemisphere. Have the anterior cerebral artery, it's the opposite in terms of the weakness. So the patient will have hemisensory loss and weakness in the lower limbs more than the upper limbs. So that's one distinct between the anterior cerebral artery infarction and the MCA, middle cerebral artery infarction. They will have abulia, which is apathy, especially if the two ACAs were affected, the bilateral, right and left. They will have urinary incontinence and ataxia as well. Posterior cerebral artery, like we said, it supplies the occipital lobe. So occipital lobe is responsible for the vision, or visual field. Therefore, they will have contralateral homonymous hemianopia, but it's characterized by macular sparing. So if we have a patient with PCA stroke in the visual field, they will have an area, circular area, that is not affected in the middle of the eye. And that's because the PCA supplies the macula, but not the whole macula. There are also supplies coming from the MCA artery. Therefore, the macula will still have supply if the PCA is affected. They will have contralateral sensory loss. They will have alexia without agraphia as well. Basilar artery, so this is posterior circulation stroke. They will have vertigo, dysarthria, dysphagia, hoarseness of the voice, hearing impairment, tinnitus, and so on. So cerebellum, the blood supply to the cerebellum originates from the vertebrobasilar system, since it's in the posterior aspect or posterior fossa. We have multiple supplies: a superior cerebellar artery, anterior cerebellar artery, anterior inferior cerebellar artery, and posterior inferior cerebellar artery. Therefore, any of the vessels will be affected will cause cerebellar symptoms. So the patient will have slurred speech, nystagmus, ataxia, tremors. That's the cerebellar signs and symptoms. If the stroke was involving the thalamus also it's supplied by the posterior circulation from the PCA. Therefore, the patient will have sensory loss. They can have some sort of weakness. They will have unreactive pupil, gaze palsy. They will have also impaired level of consciousness, because the thalamus it's one of the consciousness centers in the brain. So we move on to the approach to a stroke patient. So let's say you were on call, and then you received a call from the emergency department that the patient, male, let's say elderly male, came with symptoms of weakness, right-sided weakness, and slurred speech. So how would you approach this patient? What's the first question you have to ask about? في أحد حيجاوب؟ في أحد سامعني ولا صوتي اختفى؟
أيوة الصوت واضح دكتورة. في إجابات في الشات؟
في الشات.
أنا أقول لك إياها؟
قولي لي please.
When did the symptoms started? If they had a stroke before, الأنست since when?
تمام. So exactly. إجابات صحيحة. The first question that you need to ask, the most important question, is when did the symptoms start? Or we call it the time of last seen well. So this will convert the management differently. So if the patient presented, let's say, within 2 hours, different from a patient who presented 6 hours, different from a patient who presented 2 days ago. So it's gonna change our management drastically. Therefore, I have the most important question: is it like an acute stroke happening now, or is it subacute, few days back? This is the first and most important question. Depending on that, the following questions will come. So if it was an acute stroke, it's going to be a very focused history about the deficit itself, the last seen well time, the functionality level of the patient, if the patient is mobilizing and independent, or if the patient is bedridden, for example. It's going to be a different approach. If the stroke was like 2 days ago, you can take full detailed history at the time of presentation. But it's important to ask about the exact symptoms that the patient presenting with, and how long did it persist, and if there is any progression of the symptoms or improvement of the symptoms. So this is a key question, because if the patient had improvement of their symptoms, it's a TIA, it's different. If the patient had stable to slightly improving symptoms, it's pinpointing to us ischemic stroke. However, if the symptoms were progressing, it's it might pinpoint to an hemorrhagic stroke. Also, we have to do neurological review for the symptoms. You have to acquire more information about the background history. The main things to focus about is the stroke risk factors. So diabetes, hypertension, dyslipidemia, smoking. If the patient had any history of heart disease, any strokes before, if the patient was using any medications, any like aspirin, Plavix, or anticoagulation. If the patient was female, we have to ask about oral contraceptives. They can precipitate neurological symptoms. If the patient had any family history of strokes, and that's it. Are the main questions to ask about. Examination. We have different goals, multiple goals when we're examining a stroke patient. First of all, we need to know where is the lesion. Is it a large artery? Is it a small penetrating artery? Is it in the posterior circulation, anterior circulation? That's the main goal of the examination. Sometimes the patient, they say, oh, I have sensory loss. It's only subjective sensory loss, but when you examine the patient, it does not really show any numbness, for example. We start with vital signs, most importantly, and forever the most important is the vital signs and ABC. Regardless of the patient presentation, stroke, or any other presentations, you have to start with the vital signs. Then you go on with your examination. You examine for high cortical function. I'm sure we have a session about the examination. In this course, cranial nerve examination, motor, sensory, cerebellar, gait, and language. Language with the higher cortical function. It's not at the end, it's in the higher cortical function. Part of it is to assess the language. Should complete examination by doing cardiac exam and general examination of the patient. It depends on how you start it. You might start with general exam of the patient, how the patient looks, is he in distress or not, sitting, and so on. Then you start with neurological exam. You finish off with the rest of systems. Sometimes you start with neurological examination first. So it depends how you want to take it. Like NHS, National Institute of Health stroke scale, one of the widely used, if not the widely used scales for stroke. Especially if the patient is presenting within time frame of 4.5 hours. It's the main assessment we do. 4.5 or تقريبا to 12 hours. It's the main assessment we do, an initial assessment we do. It's the purpose of it is to grade the stroke or to determine the severity of the stroke. It's objective assessment. You don't take history, but it's the things that you see in the patient. So you don't ask about the numbness, for example, but you assess the numbness clinically. It's composed of 11 components, testing from the level of consciousness, gaze, visual fields, facial movements, and motor exam, sensory, all of the aspects of the neural axis. And we have grading for each symptom. It has its weaknesses. It's very good for anterior circulation presentation, but it underestimates patients presenting with posterior circulation symptoms. That's one of its drawbacks. Severity grading, if the patient had 5 NHS of 5 or less, it's considered minor stroke. From 5 to 21, it's considered moderate stroke. From 21 to 42, it's considered severe stroke. So for each stroke patient, we have to calculate the NHS. Any stroke, any patient presenting with stroke, we need to know if it's severe stroke, moderate or minor stroke. If a patient presenting, as I said, within a time frame of acute management, namely in 4.5 hours for TPA, and up to 12 hours for thrombectomy, this should be the initial assessment that we do. We'll move on to the differential diagnosis, or what we call stroke mimics. So there is a distinctive point of stroke is that even if you sometimes think it's a mimic, you have to overestimate the stroke. You have to think of it as a stroke until you have a different proof. Many diseases can present like a stroke. We can divide it into neurologic, non-neurologic. So neurologic, first thing is seizures. Especially if the patient has post-ictal thoughts paralysis, it can look like a stroke, or it can look like, more specifically, like a TIA. So the exact same presentation, acute onset of neurological deficit that resolved. So it looks like a TIA. Brain tumors as well, they can have acute neurological symptoms that look like a stroke. Migraine, one of the known stroke mimickers, migraine with aura, it presents similarly like a stroke. A headache with focal neurological deficit. MS as well can present, especially if they came early. Convergent disorders, it's similar also to a stroke. Acute neurological deficit that persists and sometimes resolve. As I said, if you cannot say it's a stroke while it's not, but you can think of it as a stroke, and you're going to be in the safe side. There are multiple other causes, non-neurological, like hyperglycemia. That's why one of the main things to check when the patient presents with stroke is the random blood glucose. If the patient has hypoglycemia, they can present with symptoms that are similar to a stroke. Therefore, you have to exclude it from the beginning. Wernicke's encephalopathy can present like a stroke. Hypertensive encephalopathy as well. Hypoxia, hypercapnia. Vestibular neuritis, Bell's palsy as well. Multiple symptoms multiple diseases can present like a stroke. Also, drugs intoxication can cause symptoms similar to a stroke. Investigations. We already talked about the history, how to approach patient with the stroke. Now we need to move on to how to investigate for this stroke. And sometimes it's confirmation, it confirms the presence of stroke. And sometimes the investigations will be inconclusive and the stroke will be diagnosed clinically. So in terms of imaging, نبدأ labs, then imaging. So labs, we have, as I said, serum blood glucose, CBC, electrolytes. They're especially important if the patient had bleeding. We need to know if it's causing any hemoglobin drop. We need to know the coagulation, especially if the patient is using warfarin. We need to know the troponin. Sometimes patient can present with MI and stroke at the same time. So we need to do troponin, urine, drug screening for any drug abuse, lipids as well. Later on, we might need to order the hemoglobin A1C to look for diabetic uncontrolled DM. Followed by ECG, first blood work, ECG. It's very important. One of the most important aspects of ECG is cardiac work, because the patient might be having atrial fibrillation or MI, and you don't want to miss that on the brain CT, on the ECG. عندنا برضو الإيكو، هذا part of the workup but not acutely. After we admit the patient, we do echo, Holter, to look for cause of stroke. عندنا برضو carotid ultrasound to look for carotid artery stenosis if we think it's the likely mechanism based on the patient presentation. If it's carotid stenosis, we'll do carotid ultrasound. But the best modality is the carotid CT angiogram. It will show the stenosis better than carotid ultrasound. Then we'll do imaging of the brain. The first and the initial imaging modality is the non-enhanced CT brain. It's gonna first of all show hemorrhage, and it can show early ischemic changes, like hyperdense vessel sign, like basal ganglia blurring. These are early signs of ischemia. بعدين at the admission setting or the in-hospital setting, we can do MRI if the stroke was not present on the CT brain. وعن ترتيب investigations يعتمد على acute presentation of the patient. إذا the patient جاء على طول في window of the acute intervention, investigations would be ordered differently. بس في if it's out of the window of the intervention, just regular labs, ECG, CT brain acutely, بعدين في inpatient setting, echo, Holter, carotid CT, and MRI. يعني تقريبا أكثر شيء تكلمت عنه how the patient can present acutely. Can be different from subacute presentation. ليش هذا الشيء مهم؟ إنه stroke it's a timely presentation. If the patient presented early, it's the golden window for the intervention. If the patient presented late, we cannot do any type of intervention, and any intervention would be harmful for the patient if we started it after مثلا 1 day of the presentation. في famous mnemonic or famous quote اسمها time is brain. For every minute delay for treatment of stroke, there is 2 million neurons, and some references they say 2 billion neurons lost. It's very precious time. Therefore, واحدة من الأشياء المهمة إنه we educate the patient about or educate the population, or raise awareness in the population that the stroke is needs that the patient come to the hospital very early. نتكلم عن management. We have acute management and long-term management. Acute management, depending on the patient presentation, it's a timely presentation, timely disease. The earlier the patient presents, the better in terms of intervention, in terms of outcome. But if the patient presented within 4.5 hours, they will be candidate for TPA or alteplase. It's thrombolytic therapy given IV. It's going to help with the patient's symptoms. It can improve the patient's symptoms completely. It can stabilize the symptoms, or it can prevent the symptoms from progressing. في الأحوال it's a beneficial therapy. طبعا في different indications, indications with certain NIHS, the contraindications. We'll not go through that because it needs a lot of details to talk about. If the patient presented within 6 hours to 12 hours, and they fulfill certain criteria, they will be candidate for thrombectomy, or we call it, it's called thrombectomy. So it's a catheter going through the femoral artery up to the brain and removing any thrombus that occluded the vessel. طبعا they have to have a thrombus in the first place to do this intervention, and the thrombus should be confirmed by imaging في البداية. So if the patient had symptoms and they presented in a time window for thrombectomy, but they did not have any thrombus in the imaging, they will not be a candidate for thrombectomy. This is the acute management. Long-term management, طبعا we have to give preventive therapy, maybe antiplatelet, depending on the score of NIHS, and the score, if it's a TIA, we'll give single antiplatelet or dual antiplatelet. This is our management. بعدين في المانجمنت هو for the risk factors, blood pressure control, DM. If the patient is diabetic, we need to have a good control of his blood glucose. If the patient is hyperlipidemic, we have to administer medications to lower the lipid level in the blood. If the patient was a smoker, we have to counsel the patient about smoking cessation. If the patient had a different cause for stroke, like atrial fibrillation, MI, infective endocarditis, we have to manage each patient according to the cause of the stroke. One more important thing about the management is that the rehabilitation or the physiotherapy. It's going to improve the symptoms, especially if it's started early in the course of the stroke. We'll move on to the complications. Can be divided into neurological complications and medical complications. Medical complications, patients tend to have aspiration pneumonia after the stroke, because it affects the swallowing center, and patient whenever they attempt to swallow any food or liquid, secretions or the content tend to go to the lung, and they usually suffer from that after a stroke. Also, they can have cardiac abnormalities like arrhythmia, MI. Also, they can have DVT and PE, and it's mainly because the patient was mobile before, and then after the stroke, patient became less mobile, sometimes bedridden. The affected limb, it's not moving anymore, and the blood is not circulating, especially the venous system. It's like accumulating في نفس اللب. Therefore, they tend to have DVT, subsequently PE post-stroke. Neurological complications, they might have elevated ICP, herniation, especially in the context of hemorrhagic stroke, seizures. The same area of the stroke can, on the long term, be an epileptogenic focus that causes seizures. They can have a syndrome of inappropriate ADH secretion. They can have persistent neurological deficit due to the stroke. One of the also common presentation or common complication of systemic stroke is that they have hemorrhagic transformation in the same area. So especially we see that with large strokes like MCA stroke or ACA, they tend to have a hemorrhagic transformation. And by that, I conclude my presentation. Like I said, stroke is a timely presentation. As the patient presents early, the earlier they present, the better the outcome of the patient. Therefore, we should raise awareness in the population about the importance of recognizing the patient's symptom, the stroke symptoms. An easy way to remember that is by the acronym BFAST. So B for balance, if the patient is having balance issues, eyes for any visual changes, face if the patient had any facial asymmetry, arm for arm weakness, and speech for any speech abnormalities or disturbance in their speech, and time, it's time to call the emergency for that. Thank you for listening, and I'm happy to answer any question you might ask.
الله يعطيك العافية دكتورة.
الله يعافيك.
في أسئلة في الشات. أول سؤال what makes the lacunar stroke unique is that is the site of injury only, but it can be due to hemorrhagic or ischemic pathophysiology.
شوف الأسئلة. No, lacunar strokes, it's ischemic. It's not hemorrhagic. It's not the site of the injury, but rather the vessel itself. So it's a very small vessel branching the large vessels, supplies deep, small structure of the brain. For symptoms, depending on the vessel affected exactly, but it's always ischemic. It's not hemorrhagic at all. طيب السؤال الثاني is it accepted to do LP after positive finding of hemorrhage on CT? يعني السؤال is it safe or not? Depending on if there was hemorrhage, it does not necessarily mean that the patient has impending herniation, or they can have high ICP, but it's not like they're about to herniate. طبعا هذا يعتمد على size of the hemorrhage. Is it causing midline shift or not? Is the patient having altered level of consciousness or not? فهو يعتمد على البيشنت، مو أي hemorrhage حنخاف من ال LP، فيعتمد على البيشنت symptoms. في سؤال ثاني؟ أنا بس شايف سؤالين. الله يعافيكم يا رب. كده تمام، الله يعطيكم العافية، وأنا مرة صراحة انبسطت واستمتعت بالكورس هذا الجميل.